So hello and good morning to you all. I hope you can all hear me. Thank you for joining this session. My name is Andrea Melania. I'm a level 6, you can see in the screen, medical student, and I'll also be a moderator for today. So I want to talk about XYZZ before we begin. So XYZZ Med is a vibrant community of Kenyan medical students from multiple universities. We're united by the mission to enhance medical education in Kenya. This initiative is driven by the need to create accessible, locally relevant, tailored resources that address the country's unique healthcare challenges. So the current medical education system in Kenya frequently depends on foreign resources, which may not always align with the local context. This gap may leave the healthcare professionals less prepared and contribute to a lack of public awareness regarding various medical conditions. So XYZZ Med is bridging this divide by developing various educational tools, including readable medical illustrations, case simulations, lectures, quizzes, healthcare stories, research, etc. So one such initiative is this CMEs. It's designed to promote peer-to-peer learning, and it's often peers who can break down complex concepts into understandable terms. So apart from that, I also like to take this time to encourage each of us to help us in the collection of funds and blood donations for Nuru Mugambi, who was hospitalized after catastrophic antiphospholipid syndrome, one of the possible complications of SLE. So on today's topic, today's CME topic is SLE, systemic lupus erythematosus. And our speaker is Mwenda Muriki. Mwenda is a level 6 medical student at same university. So he enjoys expressing himself creatively through drawing. So I would like to welcome Mwenda to kick off this session. So welcome Mwenda, and a warm welcome to all of you.
Thank you so much for the humble introduction. If you'll allow me, I'm just going to share my screen and then my slides so we can kick off. If you can see my screen, kindly confirm.
Yes, I can see your screen.
Okay, great. I'll be presenting in a moment. Great. So I trust you can see my presentation, the presentation slide, just to confirm that the slides are moving before you start.
Yes, they are.
Great. So again, thank you all for joining me today, this morning. Today we'll be going through systemic lupus erythematosus, SLE for short, or just lupus colloquially. As previously stated, my name is Mwenda Murioki. I'm a level 6 at University of Nairobi. So just to kick off our discussion, we'll be tackling what SLE is, the pathophysiology, the clinical manifestations, and the diagnostic criteria, the investigations that you would do for a patient with SLE, as well as the management, and a bit on complications. It's going to be a relatively brief conversation. I do not believe in having a very long presentation, as that would prevent learning. But these are the objectives for today's session. Number one, we're going to define what SLE is, go through the pathophysiology and clinical characteristics. We will highlight the diagnostic criteria that is used, and we'll go through the investigations, the management, and complications of SLE. So you will start. What is SLE? So SLE is a multi-organ and multi-systemic autoimmune disorder that causes inflammation and tissue damage throughout the body. It is a chronic idiopathic inflammatory disease with multiple factors, which we'll see. There's genetic factors, environmental factors, and hormonal factors, and these all contribute to the pathogenesis of SLE. Of note, there are different types of SLE, so we'll be mainly focusing on systemic SLE. But to mention, there's also cutaneous lupus erythematosus, there's drug-induced lupus erythematosus, and there's also neonatal lupus erythematosus. So just to be aware. But our focus on today will be on SLE. So in terms of the epidemiology, SLE predominantly affects females of childbearing age, that is between the ages of 15 to 44 years, but by no means is that an exclusive range. It affects women predominantly of African, Hispanic, and Asian descent. So as you can see from the global map, you can see the hot points in these regions. But again, patients will be seen from all over. And in terms of the male to female ratio, as we know, many autoimmune conditions have a female predominance. So the rate in SLE is 9 to 10, depending on where you read, to 1. So for every 10 females are suffering from SLE, you'll have 1 male in general in a population. So when we come to the etiology, as previously mentioned, you have genetic, environmental, and hormonal. So under genetic etiological factors, you have certain human leukocyte antigen types. Remember, those HLAs are important when it comes to antigen presentation and immune function. So specific to SLE would be HLA-DR2, HLA-DR3, as well as hypocomplementemias. Remember, the complement system is also important in immune function. Specifically, when we look at the classic complement proteins, C1q, C2, C4, we tend to find that these deficiencies in these are also predisposed to SLE. When we look at some genetic syndromes, Klinefelter's 47XXY, that is also seen to have an association with SLE. Environmental factors also come to play. Drug exposure, especially when it comes to drug-induced lupus erythematosus, things like isoniazid, hydralazine, procainamide, all have a contributing factor. Also, cigarette smoking has been shown to be linked to SLE in certain studies as well. Epstein-Barr virus infection and ultraviolet radiation. These specifically have been thought to be factors in flare-ups of SLE patients. And we will see how UV radiation has associated with the presentation of SLE. When we come to hormonal factors, hyperestrogenic states, again, it's a predominantly female disease. So hyperestrogenic states, including oral contraceptive usage, is a known etiological factor. Hormonal therapy, again, especially for postmenopausal women, when you're trying to manage them for osteoporosis, and then you also have endometriosis as well. So from the images of the diagrams, you can see the different types. Now, when we come to the pathophysiology of SLE, again, this is a very big topic, but for today's discussion, I will try to be as simplistic as possible for communication purposes. So again, much like the etiology of SLE, the pathophysiology is not fully understood. The current hypothesis takes the autoimmune, rather, it highlights the formation of autoantibodies and the subsequent reaction of these autoantibodies on the body's tissues and therefore organs and organ systems. Initially, you have a break in immune tolerance or self-tolerance, especially in the genetically susceptible individuals. We talked about the ones who have the HLA, DR2 and DR3. Rather, those individuals are predisposed. And when you have the environmental factors, such as infections, such as Epstein-Barr virus, you have a break in self-tolerance with the exposure of self-antigens to the immune system cells, to your T cells and B cells, right? Because remember, your B cells will be the ones producing antibodies. Your T cells will also be involved in being central to your immune response. So when you have exposure of these self-antigens to the immune system, this leads to an inflammatory response. As we know, inflammation involves many tissue factors, many humoral factors and cellular factors. Specific to SLE would be cytokine release, complement activation, and autoantibody production. So when you have these autoantibodies being produced, they will go to different tissues, they will bind to different tissues, and you will have both a type 1 and a type 2 hypersensitivity reaction as a result of immune complex deposition and direct damage because of the autoantibodies that have been formed. Of note, we did mention how hypocomplementemias, have an association with SLE. The classic pathway, specifically C1q, C4, and C2, when these are low, you do not have proper mopping up of the autoantigens and the immune complexes that are formed. And this leads to detection by intolerant lymphocytes. If you recall, when you were going through immunology, thymic education and development of T cells and B cells in the bone marrow and the thymus, respectively, so certain antigens in the body are not displayed to these cells when they're developing, such as in the testes, the eye, so these are immunoprivileged sites. Indeed, internal antigens also fall under those immune privileged zones. And therefore, when you have a break in self-tolerance, you have exposure of these antigens, which indeed are self-antigens, but the immune system does not recognize them as self and mounts an immune response to them. So the next slide has this diagram, which will help to explain this further. As we can see, the autoimmunity in SLE is a constellation of factors. You have the genetic susceptibility, as we've stated. You have the environmental triggers, the infectious agents, Epstein-Barr virus, and other infectious agents. We talked about the chemical exposures, hydralazine, isoniazid, your drugs, and this leads to the immune response itself. Specifically of note, the autoantibody production. Autoantibodies will also be part of the diagnostic criteria that we'll be looking for. So these autoantibodies can lead to direct organ damage, directly based on the antibodies going to target those the body cells and tissues, and then you have immune complex deposition. When you have immune complex deposition, you can have complement activation. Again, if you have complement activation, you can also have an immune response locally in the tissue, in which case that would be a type 3 hypersensitivity reaction. As well, you can also have neutrophil activation at the site, and that can also contribute to organ damage. When we come to the clinical features of the patients with SLE, again, just to note, SLE patients can present as pretty much anything. For fans of medical dramas, I believe if you've watched House, one of the current or rather long-running jokes is when they try to diagnose patients and they always have to rule out SLE. SLE is a cause of pretty much any symptom if you look at a patient, but there are specific signs that will lead you into a diagnosis of SLE. So when we have constitutional symptoms like fatigue, malaise, fever, weight loss, that definitely is one of the features you will see. Cutaneous manifestations, including the classic malar rash, also known as the butterfly rash, your photosensitivity. As previously stated, we talked about flare-ups in SLE, infections, and also ultraviolet radiation. So a lot of these patients would complain of worsening of cutaneous manifestations of SLE under direct sunlight. Discoid lesions, and that's where we get the discoid lupus, the pictures, which I will show you. You also have oral and nasopharyngeal ulceration, and these patients will also have alopecia that is non-scarring. Raynaud's phenomenon is a unique phenomenon. Unfortunately, I do not have a picture for today's presentation. However, you will note that in cold weather, cold mornings, these patients will have a restriction of blood flow. So they will have very cyanotic distal extremities, specifically the fingers. But when you put it in warm water, When the ambient temperature increases, you'll see the color coming back to normal. And there's typically an interesting appearance to the fingers, which I believe you'll be able to see in your own reading. Musculoskeletal features include arthralgia and arthritis. Of note, SLE presents with a symmetrical polyarthritis, typically of the fingers, the small metacarpal joints as well, but you can also have the elbows and the knees, and it's symmetrical. This is important to consider when you think about the differentials of SLE, which we will get to. You can also have myositis and myalgia as well, which also goes in line with the systemic symptoms. Cardiac manifestations like pericarditis and endocarditis can also be present, and specifically for SLE, you have Liebman-Sachs endocarditis. For those of you who had the luxury of reading Robbins, you can remember a picture of how the valves of the heart looked when you had Liebman-Sachs endocarditis, which is a very classic presentation. These patients will also have myocarditis, and therefore it just goes to show you that this is truly a multisystemic condition. Under the pulmonary manifestations, again, you have pleuritis, you can have pleural effusions, you can have pneumonitis, you can also have pulmonary hypertension. So even when you're doing a systemic exam, these are features that you would be able to pick up. Again, it's not just limited to the cardiac and pulmonary and cutaneous manifestations. You will also have hematologic disturbances, such as hemolytic anemias. Remember, autoimmune hemolytic anemias will present in a particular way. So if you see a patient with jaundice, palpitations, dizziness, and shortness of breath, then yes, it is something to consider. Reticulocytosis of chronic disease. So when you do your PPF, when you do your reticulocyte count, it will be raised as a compensatory mechanism. Again, these patients would also have cytopenias, leukopenia, lymphopenias, thrombocytopenias, and this will predispose to immunodeficiency. Again, bleeding tendencies would also be seen, and therefore it's important also to consider the other differentials that you will be thinking of. When we come to the renal manifestations, typically these SLE patients would also have a proteinuria of over 0.5 grams per day. They may have nephrotic syndrome again, and when you do urinalysis, you would see cellular casts. Again, these patients would have may have glomerulonephritis and will present with hematuria. And depending on how significant the kidney damage is, you would have uremia and azotemia as well. And remember, because the kidney is important in blood pressure control, these patients may also have hypertension. When we come to the gastrointestinal tract, nausea and vomiting would also be present. You would also have dyspeptic symptoms, or rather patients do present with dyspeptic symptoms, pardon me. And peptic ulcer disease would also be another manifestation. We come to the neurological system, seizures, psychosis, losing touch of reality, depression, headaches, and because of the hematologic manifestations and the inflammatory manifestations, your TIAs and your stroke phenomenon would also be present. When you look at the eyes, for those who are who have rotated in ophthalmology, keratoconjunctivitis sicca is also another manifestation of lupus. So again, I have put it in bold. SLE can present as pretty much everything. However, so we can see from this diagram, the percentages of presentation. This is an image taken from the Annals of Rheumatic Diseases from an article, recent article. And it just goes to show you that different symptoms, different systems will be affected to different percentages. And therefore, it is important to have a high clinic index of suspicion when it comes to these patients. So these are some of the cutaneous manifestations of SLE, the classic butterfly rash. I have tried to take pictures of Black patients. Again, a lot of the times we use textbooks which illustrate Caucasian patients, and therefore we may not be blessed with appreciating these features on our own local patients. So if you will bear with me, I'll be using primarily Black patients to demonstrate these clinical findings. So again, sorry for that, we have the malar rash, as we see. You can have discoid lupus, which again, in Caucasian patients would look slightly different, and therefore I've chosen a Black patient because these are the patients who will be seen in our setup. Again, the non-scarring alopecia is also another feature of systemic lupus erythematosus. By no means was that an extensive list of the symptoms. There are many resources and there are many patients. So I will encourage you after this presentation, when you are in the wards, go out and seek these patients, appreciate these findings, and so that you will not forget. When we come to the other manifestations, we talked about the hematological, the blood dyscrasias. In this PBF, you can see that this is a nomocytic nomochromic picture of chronic disease. Remember, this is a chronic inflammatory disease. But again, you can also have autoimmune hemolytic anemia, which will present with spherocytosis, of which you can see some spherocytes here, as you can see my cursor, but this is not the key finding in this picture. Schistocytes would also be seen in an autoimmune hemolytic anemia because of the hemolysis. Of note, this is a PBF, a peripheral blood film, illustrating thrombocytopenia. As you can see, there are very, very few platelets here. The small dots, very few. We can still see that there's some schistocytes as well. You can see there's one polymorphonucleoside as well, but there's very few platelets. So in a patient, you'd expect bleeding manifestations. So again, on imaging, we talked about your pleural effusion. So this is a left-sided pleural effusion. This is a chest X-ray, I believe, of an adult patient. This was taken in an AP, anterior posterior view. And you can see that there's a complete whiteout on this chest X-ray. You can see that there's no cardiophrenic, costophrenic angle. It's completely whiteout, and this is an indicative of a pleural effusion. Again, hepatosplenomegaly, this is a coronal abdominal pelvic CT. So we can see on the right-hand side, there's a splenomegaly of about 23.4 centimeters in diameter, again, or rather in length. And then on the left-hand side, you can see that there is a concomitant splenomegaly. So I have introduced a lot of symptoms. SLE is a very big disease. So how do clinicians, and indeed, how do people manage to diagnose SLE? So in medicine, we have criteria and we have guidelines. So this is a current guideline based on the European League Against Rheumatism and American College of Rheumatology. Of note, because it requires the initial finding of anti-nuclear antibodies to be present in specific titers. The details will not be labored on, but without this, we do not carry on with this algorithm, the diagnostic algorithm to diagnose SLE. I want you to appreciate the fact that this algorithm or criteria both talks about the clinical manifestations and the immunologic manifestations. And each of these manifestations has a specific weight. A score of 10 is diagnostic for SLE. So a patient doesn't necessarily have to have all of these requirements when you're seeing them. Of note, a patient also does not have to have all these requirements in the same setting, because a patient may come with a fever in one account, another account comes with non-scarring alopecia and oral ulcers, and maybe 2 weeks later comes with pleural effusion or pericarditis. Again, those are still diagnostic findings that you'd use to score this patient. So you can see there's constitutional features of fever, which gets a score of 2. You have hematologic features like leukopenia, thrombocytopenia, and autoimmune hemolysis, which get a score of 3, 4, and 4, respectively. You have your neuropsychiatric manifestations like delirium, psychosis, which gets a score of 2 and 3, respectively. And these patients can present with seizures as well, so that gets a score of 5. The mucocutaneous manifestations, you get your non-scarring alopecia, your oral ulcers, your discoid lupus, again, and as you can see, they have been scored appropriately. This presentation will be shared, so you can look at this in your own time. I want to focus on the next slide just to make it easier, especially when it comes to learning purposes, but please be aware that these are the scoring system for the clinical manifestations. When we come to the immunologic criteria, we talked about the autoantibodies. So antiphospholipid antibodies can be seen in SLE. your anti-cardiolipin antibodies, or your anti-beta-2 glycoprotein 1 antibodies, or lupus anticoagulant. Lupus anticoagulant is important because it will react with your VDRL or rapid plasma reagent, as well as your anticardiolipin antibodies, and that will give a false positive diagnosis of syphilis. So just because a patient has that doesn't necessarily mean that they have syphilis. Again, we've talked about the hypocomplementemias, and the score depends on whether you have both low C3 and C4. And then you have your specific to SLE, again, the important one would be anti-Smith and anti-double-stranded DNA antibodies. These have a score of 6. You can see it's very high. So for student purposes, Osmosis has a very nice picture that I have borrowed kindly. So you have cirrhosis, or rather, if you remember the mnemonic SOAP Brain MD, just to get you onto the diagnostic track of SLE. When we talk about serositis, that means your pericarditis, your pleuritis, and your peritonitis. So if patients come presenting with those features, that's your serositis, your S. When you come to your oral and nasal ulcers, that's your O. Arthritis in greater than 2 joints, remember it tends to be a symmetrical arthritis. It tends to be polyarticular. So if you have an arthritis, knee pain, finger pain bilaterally, again, you're thinking about that. Photosensitivity, we talked about how ultraviolet radiation is a trigger for these patients. Inquiring about that, asking whether they wear sunscreen, whether when they don't wear sunscreen, whether they have this presentation, it's important to inquire that, as that is another feature. The blood disorders, we've talked about them, the anemias, the cytopenias, the thrombocytopenia, the leukopenia. So some of those manifestations would definitely be one thing you'd want to pick out in a good history. Your renal involvement, we talked about lupus nephritis, we talked about your nephrotic syndrome. So if a patient is coming presenting with anuria and lower limb swelling and is presenting with signs of uremia, again, that would be something to consider. And the proteinuria would definitely be indicative of SLE. When you come to your positive ANAs, as we said, when you're looking at the previous criteria, positive ANAs was a particular entry point when you're looking at that guideline. Without it, it detracts from the diagnosis, and there's other things you want to consider. We talked about the immunologic manifestations and the neurologic symptoms. So again, some of these patients would be psychiatric patients. Not every patient who presents with hallucinations, delusions will have schizophrenia. They may actually have SLE, and therefore it's important when you're trying to see these patients, even if it's a psychiatric patient, always consider the organic causes of such a condition. Again, the malar rash, which is characteristic, and the discoid rash as well, would be features that will directly cue you onto SLE. So by no means is this an exhaustive list of differentials. We have seen how extensive SLE is. We've seen the presentation of SLE. So pretty much every system involved can have differentials. I've just picked on a few that are of note. So you have rheumatoid arthritis and juvenile rheumatoid arthritis in children. You can have sarcoidosis as a differential. Malignancies, we've talked about the hepatosplenomegaly, we've talked about the anemias, the constitutional symptoms. Again, lymphomas would be something you'd want to think about, and the leukemias as well. When we come to the infectious diseases, viral infections, remember EBV and parvovirus B19. Parvovirus is very interesting as it is a cause of aplastic anemia, in which case you would have cytopenias, and this patient would have anemic symptoms, would be predisposed to infection, would have bleeding tendencies. So it isn't necessarily SLE. It's important to take a good history to rule out these other differentials. Again, infective endocarditis on account of the cardiac manifestations. Lupus causes a Liebman-Sachs endocarditis, but remember, infective endocarditis can also present with the splenomegaly, can also present with the upper right quadrant pain, can present with the cardiac manifestations, and so it's important to work these patients up well and consider these differentials. When we come to investigations of these patients, again, we look at the autoantibodies specific to lupus, the most important ones are anti-double-stranded DNA antibodies and anti-Smith antibodies. As you can see here, they are present in up to 60 to 70% and are highly specific for your anti-DNA antibodies. But for your anti-Smith antibodies, they're found in 30%. But again, they are highly specific. But we said you need positive anti-nuclear antibody titers, 1 in 80. You also need to have, or you can find antiphospholipid antibodies. Of note, if you find a pregnant patient with recurrent pregnancy loss, with recurrent DVT in pregnancy, maybe has had a history of a PE, you would think of antiphospholipid antibody syndrome, and that would be important to work that patient up and manage appropriately. You'd also want to screen for your low complement levels, as that is a diagnostic finding. When we come to the full heme, we've talked about this, your autoimmune hemolytic anemias or your anemia of chronic disease. You've seen the previous PBF, you've seen the normocytic normochromic picture. You can also have your hemolytic picture as well. You'd also see your leukopenias and your thrombocytopenias when you do your full heme with your absolute and differential counts. When you come to your other investigations, again, it depends on the system involved, but because we know that the kidneys, the kidneys tend to be involved a lot, so you would want to do your urinalysis to appreciate any proteinuria present over 0.5 milligrams per day. Your hematuria and your red blood cell cast, your urinary cast as well would be important to appreciate. By extension, you'd want to do your UECs, your BUN, as renal impairment would be a feature. Your inflammatory markers would also be raised, so your ESR and CRP would be elevated. Again, we have seen the chest radiograph that we did, and that essentially is illustrating if a patient comes with features of respiratory distress, with chest pain, and you suspect that this is pleurisy, there's a pleural effusion ongoing. When you do your physical exam, there's dullness or percussion, reduced breath sounds, then yes, you do a chest x-ray to confirm, and you find that this patient has a pleural effusion, and you'd manage appropriately for that. When we come to the management, you will see we use a lot of immunosuppressive drugs, and therefore it is important to screen for TB, as you don't want to start giving patients corticosteroid therapy or immunosuppressive therapy without knowing if this patient has TB, as that has an important consideration when you treat these patients. And just to note, the VDRL and rapid plasma reagent tests that you do for syphilis are also positive in SLE because of the anti-cardiolipin antibodies. It's the same basis of technology, so just to be aware. So management. In terms of simplicity of management, it always helps to consider the supportive and the definitive management. So supportive management comes to things, the immediate issues. So if a patient is anemic, your blood transfusions, or if a patient has thrombocytopenia, your platelet transfusion as well. If a patient has an active infection, you'd want to start treating the infection. Antibiotics, again, antivirals if possible, again. Again, patient education. Remember, this is a chronic disease. A patient will require continuous follow-up in clinic, at the hospital for any other complications that can arise. And as such, a patient needs to be aware of this. This isn't a one and done thing. You don't want a lot to follow up of these patients. When we come to the definitive management, again, this is an autoimmune disease, and therefore we'd want to suppress the immune system. So some of the drugs we use are in a stepwise fashion. You can use hydroxychloroquine, which is it's one of the most common drugs used, 300 to 400 milligrams orally once a day. You can also use your oral glucocorticoids for mild to moderate disease. When you get to severe or organ-threatening disease, you can give your IV glucocorticoids as well, and you can also give your other immunosuppressive drugs. So your methotrexate or azathioprine can also be used, plus your low-dose glucocorticoids like prednisone, less than 0.5 milligrams per kilogram orally once daily. There is an option for your azathioprine, your mycophenolate mofetil, your cyclophosphamide, which again, these are more immunosuppressive drugs. So by this point, the patient, you're seeing that control of SLE is not adequate, in which case, or the severity of the manifestations are quite high, in which case you want to start with those drugs as well. Biologic drugs are also used, rituximab and belimumab. Again, these are very effective, but very expensive. I'm sure if you've had classes rheumatology or you've rotated in any IMED or pediatric ward, when they're discussing patients with SLE, some of these drugs are very expensive. So it's important to keep that in mind. It's not a one-time thing. Some of these drugs can be up to 400,000. So again, when you're trying to treat patients, you're treating patients in totality. If you're not just treating a disease, so take that into consideration. But in time, we hope that these drugs will be more fairly accessible. Now, when we talk about cutaneous lupus erythematosus, you would also want to include your topical glucocorticoids like fluocinolone, and you can also include topical calcineurin inhibitors like pimecrolimus. For drug-induced lupus erythematosus, again, drug-induced, you discontinue the drug that is causing the lupus and manage accordingly. And then you treat any other comorbidities. And MDC, multidisciplinary care, is important when you're tackling these patients. Again, the cardiac manifestations, you may want to consider a cardiologist on board. The renal manifestations, you'd want to consider a nephrologist on board. The CVS, the neurological manifestations, it's important to at least consider having your internist, your neurologist on board as well. Now, again, this is by no means an extensive slide. This is just to help you appreciate some of the complications that can arise. So you can have your infections and both on account of the lupus itself and on account of the treatment, right? Because you're using immunosuppressive drugs, it's important to also look out for infections and treat them accordingly. We talked about your renal damage, and on top of your end-stage renal disease and your CKD, you can also have hypertension developing, and you need to look out for that. Your thrombosis as well. Lupus can have thrombotic phenomena. Renal damage can have thrombotic phenomena and bleeding phenomena as well. So it's important just to be on the lookout for that. Again, you don't want to be treating a patient for them to die of a PE. So always just be aware, and in which case I should have put your coagulation profile should be one of the investigations that you'd want to look for, especially if a patient is having these thrombotic phenomena. Atherosclerosis can also occur in these patients, and MIs and strokes would be something that you'd want to look out for, as well as specific organ damage. So this is a reference slide. You will have this presentation. You can look at these sources as well. And thank you for your attention. I hope that this presentation has been concise enough for today's session.
Yes, thank you so much, Mwenda, for that insightful presentation on SLE. I believe we've all gained valuable knowledge that will impact our understanding and management of this condition. So as Mwenda has mentioned, SLE is often referred to as the great imitator. So we should be on high index of suspicion as practitioners to diagnose this disease. So before we wrap up, I'd like us to engage in a quick Kahoot session to reinforce some key points from today's talk. So this will be a fun way to test our knowledge and review what you've learned. Okay, Mwenda, could you answer the questions first? There's a question in the chat.
Yes, I can see. How will you be able to differentiate between SLE and other autoimmune infections like Kawasaki's disease? Thank you for the question, Ashley. So yes, Kawasaki's disease is it's a vascular disease, as we know. When we come to the diagnosis of SLE, it's always important to at least appreciate the mnemonic, right? And the guidelines. So Kawasaki's will present with certain features, and SLE will present with certain features as well. So if you consider the constellation of the cutaneous manifestations, again, the malar rash, the discoid lupus, if you're thinking about the chest symptoms, yes, Kawasaki's can have similar manifestations, but it's really about thinking about the risk factors for that patient. Kawasaki's and SLE, some risk factors would be similar, some would be different. When you're thinking about the drug use, when you're thinking about some of the key features for SLE especially, it will help you kind of differentiate. But I do agree, there are a lot of diseases which mimic SLE. Therefore, the index of suspicion has to be high. So if I'm not mistaken, I believe Kawasaki's has the classic strawberry tongue as well, if I'm not mistaken. So again, that's another key feature that you'd want to be able to tease out in, on inspection or even on just history taking of this patient. Again, the age group as well is also important to consider. I hope I've answered your question.
Yes, Kamau was agreed. So thank you so much, Mwenda. Let me share my screen so that you can get to the Kahoot session. So if you could stop sharing your screen. Okay, thank you. So I hope you see my screen. I'll share the game pin and then you can join from your end. So you can either scan the code or insert the game pin directly. Okay, I see no one is using their real names. Let's see. Nice, people are joining. So give us like 2 minutes. So for everyone to join. Okay, right now we're at 17. I don't know if anyone else wants to join. I still wait for a minute and then I'll close the joining link. Right, fantastic. So I think we'll get started. Remember, this is a chance to learn and recap, so no pressure. Just enjoy. I hope you're ready. I think, okay, yeah. It is. So what type of disease is SLE? The choice is there. And I can always answer first for more points. Or you can take your time for more accuracy. Yes, so the correct answer here was autoimmune disorders. So I think most of us got it correctly. So next question. First, the scoreboard. So currently, NM is leading, then SLE, then Fortune, and we have S and Ruto following closely. So next question. Which demographic is predominantly affected by SLE? Yes, so most of us, all of us got it correct. So women age 15 to 44 years, reproductive years. That's okay. So let's see at the scoreboard. So NM is still leading, then SLE, and Ruto has gone to the third spot. Let's go to the next one. Question 3, which environmental factor can trigger SLE flare-ups? Yes, so 13 of us got it correct. UV radiation exposure is the correct answer. So let's see the scoreboard. Yes, NM is still leading, then Ruto at number 2, then Fortune has gone to number 3. VM has the highest answer streak of 3. Well done, well done. Next question. What is the primary pathological mechanism in SLE? Yes, so the correct answer was formation of autoantibodies. Let's see the scoreboard. NM still at number 1, Fortune at number 2, and then Ruto number 3. So next question. We still have about 8 questions. So which organ system is not typically involved in SLE? Nice. Endocrine system is the right answer. So most of us got it correct. Let's see the scoreboard. NM is still leading, followed by Fortune, still Ruto. Sky has the highest answer streak of 5 up to now. So our next question. Which antibody is highly specific for SLE? Fantastic. So most of us got it, anti-dsDNA. Yes, and anti-Smith antibodies, the other one. So let's see the scoreboard. Still NM at number 1, Ruto, and then Fortune. Ruto has gone to second place. Next question. We're already halfway. Which of the following is a common cutaneous manifestation of SLE? Yes, the answer was butterfly rash. Okay, now Fortune is on second position, Ruto has gone to third position. So NM is still leading. Question 8, what type of hypersensitivity reactions are involved in SLE? Okay. Okay, 8 of us got it correct. It's type 2 and 3. So scoreboard, wow, NM still leading, Ruto, Fatun, O, and 85 following closely. Question 9. What is the treatment of choice of mild SLE cases? Is it antibiotics, hydroxychloroquine? It's so fast. Yeah, most of us got it. So hydroxychloroquine is the right answer. This is change the scoreboard. So Fortune has got second place, Ruto third place, and M is still leading. So next question, question 10. Which serious complication can arise from renal involvement in SLE? Yeah, that was a bit simple. So glomerulonephritis, good stuff. So scoreboard, NM still on top, followed by Fortune. Ruto has dropped to fourth place. Still have a chance, Ruto. So next question, which diagnostic criteria is most widely used for SLE classification? So it's a CRU LAR 2019 criteria. So 10 of you got it correct. Scoreboard, okay, Ruto back to third place, Patun second place, and then first place. So next question, the second last, what's the typical finding on a urinalysis for a patient with SLE-related nephritis? Yes, all of you got it correct. So proteinuria and cellular casts. Scoreboard, Ruto to second place, Fatun third place, NM still leading. Next question, which medication is considered the cornerstone of long-term management of SLE patients? Okay, this one was a bit tricky, so only 3 got it correct. The correct answer is hydroxychloroquine. So the scoreboard, see if there's any changes. Okay. Wow. Fatun in first place, 85 second place, and then hey, Automenda Piruto. Yes, next, the last question. Hope. Yes, 14 over 14. What is the appropriate treatment adjustment for a patient with drug-induced lupus? Yes. 14 of us got it correct. Discontinue the offending drug. That's the correct answer. So, moment of truth. See the podiums. So at number 3, we have NM. Good job, NM. Number 2 is number 85. And number 1 is Fatwin. So good stuff, guys. The runners up are MC at number 4, number 5, having question number 5. So could the winners unmute and say something? So we'll start with number 3 and M. A few words of inspiration. Are you able to unmute or identify yourself? Okay, so maybe number 85. So just say your name so that you can know you. Number 85.
Hello, guys.
Hello. What's your name?
Oh, my name is Ngede.
Okay, good job, Nyebe. I think we'll go to Fatun. Fatun, are you able to unmute? Maybe say full names, define which university level.
Hi guys. I used my real name. Actually, I didn't use a nickname.
Nice. So, anything else? Which level are you? Which university?
Year 5.
Year 5. Your end. Okay, congrats, Fatun. So I don't know if there are any awards. I'll talk with Felix, see if there are any awards for the winners. But yeah, so thank you all for participating. I think I hope today's session has been both enlightening and enjoyable. A big thank you again to Mwenda for sharing your expertise. We look forward to seeing you all at our next CME event, which will be next Saturday. So take care, everyone, and have a good weekend.
Thank you.